going to go ahead and start, everyone. Welcome to Silverado. We're lucky today to have our guest speaker tonight is going to be Dr. Manisha Kochhar from UCLA. She's going to talk to us about strokes, and we're pretty excited to have her. So I'll let you go ahead and introduce yourself.
Thank you so much. Hi, good evening, everyone. My name is Manisha Kochhar. I'm a cardiologist with UCLA in Palos Verdes. We have a relatively new office there. And so I was asked to give this talk today, and thank you for having me.
You're going to have to talk to that.
Okay, I think I will. Is this better? Okay. I'd like to make this as interactive as possible and as informative and helpful to you as possible. So if at any point you have any questions or you want me to stop and elaborate on anything, just let me know. Or if you feel like I'm not speaking loud enough, please let me know. Okay?
Those kind of microphones.
Okay, so I wanted to talk about stroke today, and the three things I wanted to cover and hope that you understand by the end of the night are understand the signs of a stroke. It's important not just for yourself, but also for neighbors. Sometimes people don't even realize they have a stroke until one of their neighbors points out that part of their face is drooping or something is wrong. I want you to understand the different types of strokes, and I won't get too technical, but it's important because the treatment of different types of strokes are different, and in fact they're opposite depending on what type of stroke that you have. And number 3 is to understand and minimize your risk factors for stroke. Every one of us has some degree of risk, and knowing what your risk factors are individually, it can help minimize and treat them. So let's start out with the very basic definition of what is a stroke. So a stroke occurs when there is reduced blood flow or bleeding within the brain. And so earlier I was talking about treatment of a stroke, and it's opposite. When it's not enough blood flow, your goal is to reestablish blood flow. And if it's too much blood flow, you want it to stop. And so understanding the different types of stroke is very important. So just to give you a little bit of background of the statistics, almost 800,000 Americans have a stroke every year. So that on average, every 40 seconds, somewhere in America, somebody's having a stroke. They're not necessarily all fatal, they're not all necessarily going to lead to disability, but they do have impact on people. And of those, nearly 129,000 people die every year from a stroke. It's the number 5 cause of death in the U.S. So it's something that it's going to affect, if not you, it will likely affect a family member or a close friend. So the risk factors for stroke. One of them is age. Greater than age 55 is a huge risk factor. We see it more predominantly in African American people. Somebody that has had a prior stroke or TIA, you may have heard of that, we'll go into that in a minute, or a prior heart attack are all at higher risk for a stroke. Somebody that has a family history of heart disease is at higher risk. Being overweight, people that smoke, having uncontrolled high blood pressure, having uncontrolled high sugars, and uncontrolled high cholesterol are all risk factors for a stroke. So the next question is, what are the symptoms of a stroke? How do you know if someone's having a stroke? One of the first things that we look for is paralysis or weakness of muscles. And so this paralysis or weakness can be on one side or it can be on both sides, and it can oftentimes affect just one area of the body. So I wanted to show you this picture, and it's a picture of a woman who's had a stroke. And you can see on the right-hand side, she's smiling, both sides of her face are even, her eyes are open evenly. But on the left-hand side, you can see that there's a bit of a difference. On the right side, her eye is not able to shut properly, the right side of her face is drooping a little bit, and so she's not, you can see that she's lacking the folds right here, she's not able to form the same expressions, and she's having a stroke localized to a side of her body. She might not, if she's living by herself, she may not even know that she's had a stroke, but oftentimes it takes looking in a mirror or being around somebody else to point this out. And here's another example of a localized stroke. So this gentleman, you can see, unlike the last patient, he's able to smile properly, both sides of his face are even, but here he's unable to hold up the right side of his hand, so the stroke is affecting just part of his body. So strokes are kind of variable in their presentation. They can affect the entire body, one side of the body, just part of the body like the face. It can be one arm, both arms, one leg, both legs. And so these are symptoms that we need to look out for. Another sign or symptom of stroke is impaired vision. And this again is also very variable. Sometimes a part of somebody's visual field can be compromised, where they can see the right-hand side of the screen but not the left-hand side of the screen. Other times it could be something a little bit more subtle, where the screen appears very blurred and visual field appears very blurred. Other signs and symptoms of a stroke are difficulty swallowing. This is oftentimes related to paralysis or dysfunction of the muscles in the throat. Confusion or reduced alertness. Sometimes people have difficulty waking people up. They're difficult to arouse. People can have numbness in a part of a body where they're poking themselves or they get a cut and they don't even feel it. That can be a sign or symptom. People that have dizziness or loss of balance. And other times people can have headache or vomiting as a first sign of stroke. So these are all symptoms to keep in mind. The American Heart Association uses this acronym FAST, or F-A-S-T, to help spot a stroke. And so what we recommend for people is F stands for face drooping, A stands for the arm weakness, S stands for the speech difficulty, and T stands for time to call 911. So if any of these symptoms occur, face drooping, arm weakness, speech difficulty, it's best to call 911 in these cases. In patients that have a stroke, there is a degree of importance of time. For some patients, the earlier you get to the hospital, the better the potential outcome is. So it's always best to call 911, even if you have a suspicion of a stroke. Any questions before I go on to the next slide about the types of stroke? Okay. So there's three main types of stroke, but I'll actually break it down into two. So we oftentimes hear something called a TIA, and that stands for a transient ischemic attack. And that basically means that a part of the brain is compromised, but it recovers fully. We oftentimes used to say in the past that if somebody has symptoms for only 24 hours and then they recover, that's a TIA. But the definition has changed a little bit. And now if somebody has dysfunction that's resolved completely and there's no permanent brain damage, that's a TIA. And then a TIA can better be broken down into two ways, hemorrhagic or ischemic. And this is what I wanted to go over and how you treat strokes differently. So the different types of strokes or even TIAs are hemorrhagic, meaning that it's bleeding. The other kind is ischemic, meaning that there's low blood flow. So the hemorrhagic stroke is bleeding within the brain. And so hemorrhage refers to bleeding. So patients that get bleeding within the brain are those that have high blood pressure. When the blood pressure becomes too high, the blood vessels in the brain can burst. Patients who've had trauma, if somebody's been in a car accident and they hit their head, there can be bleeding within the brain. Somebody that uses drugs, for instance, cocaine, the blood pressure becomes very high. Somebody that has bleeding issues, some patients may be on a medicine called Coumadin or Xarelto or a different blood thinning medication, and if even a slight injury to the head can cause bleeding in somebody that may not be on that medicine. And other times there's something called congenital, where somebody's born with a little bit of malformations of the blood vessels in the head, and they're more at risk. Those ones are a little harder to diagnose because we can't necessarily predict who has those malformations, but if somebody's on bleeding medicines that make their blood a little bit thinner, they're at higher risk. And then another cause of hemorrhagic stroke is rupture of an aneurysm. And so this is what I was talking about, the rupture of an aneurysm. In the brain over here, we have blood vessels throughout. And sometimes people are born with, or over time they acquire something called an aneurysm, which is this bubble here, and it's a weakness within the blood vessel wall. And because this balloon is the wall becomes so thin because it's so expanded, there's a lot of pressure on there. And over time, if there's high blood pressure, or if something happens, or even trauma that causes this to rupture, that can cause bleeding within the brain. And then when people talk about ruptured brain aneurysms, that's what we're referring to. Okay. And the other type of stroke that I wanted to talk about is called ischemic stroke, or low blood flow. And so in these patients, there's not enough blood flow flowing to the brain. And this is an example of an ischemic stroke right here. So here we talked about the hemorrhagic, where the blood vessel breaks and there's blood flow within the brain. And this is the other kind, where it's ischemic and there's no blood flow within the brain. There's blockage of this blood vessel over here, so the blood can't get through. Okay. And there's a few different reasons why people have ischemic or low blood flow strokes. Number one, there can be a blood clot that forms. Just like patients have heart attacks where a blood clot can form within the artery of the heart, compromising the blood flow, a blood clot can form within the arteries of the brain, causing diminished blood flow there as well. And just like the heart, people can get blockages in the blood vessels with cholesterol and plaque deposits. Same thing with the blood vessels of the brain. They can get plaque deposits in blood vessels, which impede blood flow. There's another thing you may have heard of called an embolism, and that's where some blood clot or some infection travels from one part of the body to another part of the body. Sometimes patients develop blood clots in their heart. If it travels up to the brain, that's something called an embolism, and that can cause diminished blood flow as well. It is scary. It is.
My son just,
An embolism?
he had a blood clot in his heart.
Yeah, there's definitely patients that are at higher risk for blood clots, and all of this stuff sounds so scary, and you wonder who can prevent this, but we're going to get to that a little bit later. Who's at risk for these, and what you can do to prevent this from happening from you, and and how we can diagnose who is at higher risk. And then the final cause of low blood flow is low blood pressure, and this we usually see in patients that are having trauma where they're losing a lot of blood and they're not able to maintain a high blood pressure. They're just not getting enough oxygen to the brain. But the thrombus, number one, blockages of blood vessel, and embolism are probably the three most common causes. And I wanted to show you the differences between a blood clot and an atherosclerotic plaque. So this is the brain over here, and these are the blood vessels that give blood to the brain. When people get plaques or atherosclerotic plaques within the heart, they narrow the blood flow to the brain, and it narrows the blood flow to the brain over time. And so patients aren't able to get adequate blood flow, resulting in a stroke. And this is a little bit different. This is a blood clot, and this can be either in the form of an embolism, where something in the heart travels to the brain, or it can be something that forms within the brain blood vessels themselves. And this is usually an immediate thing. The atherosclerotic clot occurs over time. This is something that's a little bit more immediate, where patients all of a sudden develop symptoms. So the next question is, how do we diagnose a stroke? Usually when patients go to the ER, the first thing that's done is a CT scan. And this is why I told you the importance of timing. The faster you go to the ER, the faster all of this can get done, and the better likelihood you have for improved survival. So the first thing they do is a CT scan. The reason they do that is they want to know if somebody is having a bleeding within the brain, or if they're not getting enough blood flow. The way we treat it's very different. If someone is bleeding within the brain, your goal is to stop the bleeding as soon as possible. If you're not having enough blood flow, your goal is to reestablish blood flow as soon as possible. And so the first thing that they do is a CT scan in the ER, because they want to identify what type of stroke you're having, because that determines the next step of treatment. So this is a patient that had a large stroke, and this particular patient, they had bleeding within the brain. The last thing you want to do for this patient is give them aspirin or something that's going to cause them to bleed some more. So the CT scan is the first thing that you do. After the CT scan, they usually will do an MRI. An MRI is not done first because it takes a lot longer to do, about 45 minutes versus 5 minutes for a CT scan. And so the MRI is more useful because it kind of tells you how big the stroke is and what areas of the body are going to most likely be affected. And sometimes you can't necessarily diagnose a stroke with a CT scan or an MRI, and in these rare cases, they need to do a spinal tap. And so we were talking about how to treat a stroke. And again, it depends on the type of stroke. If you're having an ischemic stroke, meaning that you're not getting enough blood flow, the first thing you want to do is to reestablish the blood flow. And we often give these clot-busting medicines. These must be given within a 3 to 4.5 hour window after the symptoms start. So sometimes patients will wake up, they're not feeling so good, they feel weakness, and they say, you know what, I'll just take a nap, I'll wait it out, see if I'm feeling better in a few hours, but they're losing time in that window. If they're not in the hospital within 3 to 4.5 hours, they're no longer a candidate to get these medicines, and that's going to impact their long-term outcome. So these clot-busting medicines are very important to give in that small time frame. And that's the importance of getting to the hospital very rapidly. If, on the other hand, somebody has a hemorrhagic stroke, the other type of stroke where they're bleeding within the brain, the next thing we want to do for these people is to stop the bleeding. If they're on a blood-thinning medicine, we can give antidotes to those blood-thinning medicines so they don't bleed so easily. And so the next question is, how do we prevent strokes? So we had talked about some of the risk factors earlier. Things that we can work on as people are, we can't change our genetics, we can't change our family history, but we can change what we're eating. Can we change our weight? Yes, we can change how inactive or how active we are. We can work on getting our cholesterol down. That includes both diet as well as medicines in some people. We can control how high our blood pressure is. That's both lifestyle in terms of exercise, how obese we are, how much salt we're intaking, but also how well and how regularly we're taking the blood pressure medicines. Diet is very important. diabetes. Diabetes, when people have it, it's not always within their control, but how well your sugar is controlled, that can be controlled. And then smoking, that is the one thing that we reckon that has no benefit at all and only has bad outcomes. So to talk a little bit about obesity, we measure something called the BMI, or the body mass index. When somebody is 5 foot tall and 200 pounds, that's very different than someone that's 6 foot tall and 200 pounds. So we take that height and that weight into account. We call it the BMI. So somebody with a high BMI, meaning a high weight for that particular height, has a 2 times greater risk of stroke than somebody with a normal BMI. Physical inactivity, highly active individuals, meaning somebody exercising about 30 minutes a day, 3 to 5 times a week, has a 27% lower risk of stroke. This also, a lot of people these days have very computer-driven jobs where they're sitting in front of a computer for long periods of time, not getting up. They just walk from their car to the office, sit in the computer, go back at the end of the day to the car, and they're not exercising during the day. So even if you know somebody that has a job that they're physically inactive, that also portends a higher risk of stroke. So physical activity, just small things like taking the steps, or taking instead of taking the elevator, or parking a little bit further away in the car can do wonders long term. Diet. Patients with the high diet, those listed below, have a 30% higher risk of stroke. So people that eat smoked or processed meats, people that eat red meats, trans fats, high quantities of salt, and diet sodas. Diet sodas are notoriously bad, are all portend higher risk of stroke. Okay, diabetes. So about 8% of the people in the United States, about 26 million people in the U.S. currently have diabetes, and people with diabetes are 2 to 4 times more likely to have a stroke. So in diabetes, the body doesn't make either enough insulin or too much insulin, so patients are not able to metabolize or process their sugar appropriately. That results in sugars that are too high in the blood. Overall, when the sugar remains too high in the blood, there's fat deposits on the blood vessel walls, and that leads to a stroke. So some of you may have diabetes or may have symptoms of diabetes, but just briefly to go over the symptoms of diabetes, some patients that are always tired, they need to go to the bathroom and urinate frequently. Sometimes patients will have sudden, unexpected weight loss, or may have wounds that wouldn't heal, just a small cut or a paper cut even that won't heal. That could be a sign. People that have erectile dysfunction. People that are always hungry, no matter how much they eat, they're never satisfied. That could be a symptom of diabetes. When diabetes is there for some time, the vision can get affected. So people that have blurry vision. Numbness or tingling of the hands and feet. Long-term diabetes can affect the nerves in your body, and so your hands or feet can tingle. Patients that are always thirsty, and patients that have infections that don't clear are all signs that your sugar should be checked. Could be a sign of diabetes. Another risk factor, high cholesterol. So cholesterol, it's not inherently bad. Your body needs some cholesterol to function, and your body does produce cholesterol. But it's when we intake too much, mainly in the form of diet, that it becomes a problem. Some patients, they just have a genetic predisposition to high cholesterol, and these patients unfortunately have to take medicines. But monitoring it regularly and treating it if it is too high is very important. Too much cholesterol can circulate in the bloodstream and can also accumulate in the body. And this is an example of that. So this right here is an atherosclerotic plaque, and you can see that where this blood vessel divides into two, those regions are very vulnerable for plaque to deposit. And over time, if this narrows significantly, it's going to reduce the blood flow to the brain. It's very similar to what goes on in the heart when people have angina or chest pain, is that these vessel walls in the heart, just as in the brain, become very narrow, and people can have blockages in the heart. Symptoms like problems like this can lead to the TIA that I was talking about earlier, where people have a temporary lack of blood flow. So they might have some blood flow, but it's not enough, and they might have some symptoms. And that's why a TIA is also something very important to treat and pay attention to, because it can lead to a stroke long term. So people always talk about high cholesterol. What is high cholesterol? What are my targets? So we typically like a total cholesterol less than 200 in patients. The LDL, or the bad cholesterol, I use the term L stands for lousy. So the bad cholesterol or lousy cholesterol should be less than 100. If If patients are kind of low risk, they've never had a stroke, they don't have any other problems, I'll tolerate as high as 130. But if patients have had a stroke, or if they're over age 55, if they have diabetes or any other risk factors, I'm very aggressive about getting their LDL down. Patients should have a triglyceride level of less than 150. Over 150, you put yourself at risk for pancreatic problems, liver problems, and other problems. So less than 150 is good. People ask, why are my triglycerides high? Triglycerides are a direct reflection of how many carbohydrates you intake. So cookies, cakes, rice, pasta, all of that leads to high triglycerides. So this is something to keep in mind. And HDL is I mistyped that. HDL is the good cholesterol, and that one should be higher than 40. And that's what we look at when we look at a cholesterol profile. This is probably one of the most important things in high blood pressure. Untreated high blood pressure is one of the leading causes of stroke. About 70 million American adults right now have high blood pressure, and that affects about 1 in every 3 people. So if there's about 15 people in here, 5 of us here have high blood pressure, and only about 50% of them have it under control. The cost to the nation yearly? $46 billion, if you think about it, due to high blood pressure. And that's from heart disease, stroke, kidney damage. The effects of high blood pressure are just so high. It's truly the greatest risk factor for strokes. It damages the high blood pressure over time, damages the blood vessel walls, causes irritation in the walls, causes the plaque to deposit, and that's what leads to the ischemic stroke. But just like it leads to ischemic stroke, it can also lead to the hemorrhagic stroke, the other type of stroke. I showed you the previous picture of the aneurysm where the vessel was ballooned out. If you combine that balloon with a narrow wall with very high blood pressure, that's going to rupture. And so high blood pressure puts you at risk for both ischemic and hemorrhagic strokes. So what are normal blood pressure numbers? So our goal for patients is around 100, not more than 120 over 80. Once you start getting over 120 over 80, at the bottom you enter what we call pre-hypertension. And then once patients reach 140 over 90, they're in the hypertensive state. And that's when we start treating people with medications. So we typically don't, the first time you come into the office and your blood pressure is high, it doesn't mean we're going to start you on a medicine right away. Some patients have what's called white coat hypertension, where when they're in a doctor's office or they're around a medical setting, their blood pressure becomes a little bit higher. So in these patients, what I recommend is that they go to the local CVS pharmacy, Rite Aid, or even buy a blood pressure cuff at home and just check their blood pressure cuff when they're out and about doing their normal activities. What I want to make sure is that somebody's blood pressure is normal all the time, not just when they're seeing me, not just when they're home, but all the time that their blood pressure is normal. So how do we treat high blood pressure? So in many patients we do have to use medicines, but we also recommend non-medicinal approaches as well. Salt restriction, reducing how much salt you take. A lot of prepared foods that you buy, even something as simple as chicken soup that you buy from the grocery store, is so rich in salt. Reading those cans, reading those labels is very important. Weight reduction reduces blood pressure tremendously. I've had patients that were on maybe 3 or 4 blood pressure medicines, but as soon as they lose weight, we are able to take off the medicines. I consider that a success. Avoidance of excess alcohol intake. Too much alcohol can definitely lead to high blood pressure and ultimately stroke. And number 4 is regular aerobic exercise, and that's 30 minutes where you're getting your heart racing a little bit, where if you were to talk to somebody, you might be a little short of breath. That's our goal for aerobic exercise. 30 minutes, 3 to 5 times a week is ideal. And then the next most important is stopping smoking. So one person every 6 seconds dies from a smoking-related disease, whether that's emphysema, COPD, stroke, heart attack. If you smoke 20 cigarettes a day, you are 6 times more likely to have a stroke compared to a non-smoker. So it's definitely something to keep in mind. And so how does smoking cause strokes? More than 7,000 toxic chemicals are found within cigarettes. Cigarettes increase your cholesterol levels. Cigarettes cause damage to the blood vessels throughout the body. There's chemicals within those cigarettes that we call free radicals that damage the blood vessels within the body. Smoking makes people's blood more likely to clot, and so it actually can form blood clots within the heart and other areas of your body. And then patients with smokers are actually more likely to develop high blood pressure. And one more thing one other risk factor for stroke is something called atrial fibrillation. Has everyone heard of this before? Some of you, yeah. So atrial fibrillation, and this is more heart-related, more in my department, but it's an irregularity of the heartbeat. In patients that have long-standing high blood pressure, or some people that have an abnormally shaped heart, can develop something called atrial fibrillation, which is this irregular heartbeat. Sometimes the heart will beat fast, but sometimes the heart will beat normally, but it just won't be the regular thumping. It'll be a little bit more irregular. And so this is a picture here of an EKG, and this is each heartbeat. And you can see that the distance from here to here is very different than the distance from here to here. And that suggests that there's an irregularity in the heartbeat. In a normal heart rhythm, every single beat should be very regular, and there should be an equal distance between each of them. When patients have this condition called atrial fibrillation, they're more likely to form a blood clot within the heart. If that blood clot forms in the heart, the next place it circulates is up into the brain.
That's nice to know.
It's important to know.
I have AFib. She has AFib.
Well, so we'll get to how to treat that in a second, but even just knowing, many patients are walking around not even knowing that they have atrial fibrillation. They don't necessarily have symptoms. Yeah, and so just even getting that simple EKG is a screening test that all of you can do to lower your risk of stroke. So this is a regular heart. This is called the right atrium, the right ventricle, the left atrium, and the left ventricle right here. And so what happens in atrial fibrillation, the heart up top here fibrillates, or it kind of spasms. So this top part of the heart doesn't beat regularly, and so blood clots can actually form in this area right here. If a blood clot forms within this area called the left atrium, the next thing it does is it goes to the bottom part of the heart and then out the aorta, which is the big part of which is the major blood vessel in the heart. That aorta distributes blood to every single part of your body, including your brain. And so this blood clot can go up there and cause stroke.
Have you ever, when I was on, she's asking this, when I was much younger, when I first started having AFib, I used to take and push on my carotid artery right here, or my arteries right here, and then I let go, and then I push again, and then I let go, and then I bear down like you're having a bowel movement.
Yeah.
And it would put my heart back in the.
Yeah.
And she was afraid to do that.
Yeah, so that's something, what she's describing is something called a Valsalva maneuver. And basically, in some patients, it doesn't work in everyone, but it can actually kind of reset your heart a little bit. We use it more, not so much in patients with AFib, but in patients that have something called supraventricular tachycardia. Basically, what that Valsalva does is it stops the too fast heart, it stops your heart from beating too fast, and it can actually slow it down a little bit. So it's useful in some patients, but it can also be a little bit dangerous. If people have a lot of blockages in the arteries over here, you can actually dislodge some of that plaque and cause a stroke that way. So better than pushing on your neck, it's better to bear down, like you're having the bowel movement, rather than agitating the cholesterol within the neck arteries.
Well, it doesn't work on me anymore.
Yeah.
I have skip a beat.
Yeah.
I don't really get the palpitations anymore. I just skip a beat.
Right. So in that supraventricular tachycardia, it's a lot easier to do. It's more effective than in atrial fibrillation. But once patients have had atrial fibrillation a long time, those maneuvers don't help too much. So this is an example of a patient with atrial fibrillation. This is that left atrium of the heart where the blood clot forms. The next stop it goes is the bottom of the heart. And this is the aorta, or the big blood vessel of the body. The first branch off of this is to the brain, and you can see that a blood clot can easily travel up to the brain, causing a stroke. So that simple EKG that I showed you, it takes about 2 minutes in the doctor's office. That can give you the diagnosis of atrial fibrillation. And having the diagnosis is important because we can treat it. We can either try to get you back into the normal heart rhythm, or we recommend some blood thinners in patients. And there's a few medicines that are on the market right now called Pradaxa, Coumadin, Xarelto. These are just a few of them. But the other thing that we try to do is we actually give patients an electrical shock right up there and try to reestablish the normal heart rhythm. It works when people first get into atrial fibrillation, and we try to give them medicines to keep them in the normal rhythm. But if patients have been in atrial fibrillation for a long time, their heart sometimes remodels, and it's hard to get them back in with shocking, and the shocking becomes ineffective. But initially, when people are first diagnosed, it can be successful, and that's why early diagnosis is very important. So the next question is, what do I do if I already have a stroke? You're told, if people see on the news, they see on commercials that if they have a heart attack, the first thing to do is take an aspirin. But that's not necessarily true for somebody that's had a stroke. We talked about somebody that's bleeding too much. You don't want to have aspirin if you're having a bleeding type of stroke. So the first thing to do is to go to the emergency room, and they can do the CT scan, help decide what type of stroke you have, and they'll go from there. So if somebody has an ischemic stroke, the next step is aspirin or another medicine called clopidogrel. But again, wait for medical advice before you start doing that yourself. In patients that have had blood clots, sometimes blood thinners are effective. We talked about Coumadin, but there's other IV medicines that can be used to help break up clots. Sometimes if there are blockages in the arteries that supply blood to your brain, you can unblock them. There's surgical procedures where they can actually remove the plaque from the arteries. Also, reducing risk factors at that point, being very aggressive about high blood pressure, very aggressive about diabetes control, very aggressive about cholesterol control, and stopping smoking. Those are things that you can do if somebody's already had a stroke that we can work on. So that's what I wanted to talk about today, but I want to keep this open at this point for any questions that you might have. Yeah. Go.
I'm sorry, it's sort of related to her questions. You mentioned AFib can be the result of high blood pressure over many years that was treated or not treated.
So her question was atrial fibrillation resulting from high blood pressure. If the high blood pressure is not treated over time, so let me kind of tell you this way. So if somebody wants to lift weights, you're going to see their muscles start getting bigger. Your heart's kind of the same way. Your heart's a muscle. So every time your heart beats, if it's pumping against a high blood pressure, it's going to have to work harder. And just like your bicep when you work out, your heart muscle is going to become a little bit thicker. And so the heart becomes thick. And then the blood doesn't flow into your heart as well once it becomes thick. And that's what leads to atrial fibrillation. The left ventricle or the bottom part of the heart becomes thick, the muscle becomes thick against all that pressure, and then the top part of the heart, the atria, it has to expand a little bit, and that's what leads to atrial fibrillation. So if the blood pressure is controlled, you're less likely to get the atrial fibrillation, but if your blood pressure is poorly controlled or not treated, then you're more likely to get it.
Because years ago, they were worried about the 120. For a while, they were worried about the lower number rather than
Yeah.
the top number. And it's funny, things change, but it's hard for the layperson to keep up.
It's true. It's even hard for the physician to keep up. Even within the last year, we use different guidelines that come from different sources, and the guidelines, even for physicians to follow, have changed twice within the last year. So it's hard for everyone to follow through. But regular visits to your doctor, who are up to date on the current literature, is probably the best thing you can do. One more question.
If somebody shows up in the ER with a broken face, they would like there. How does the ER determine whether it's a stroke or Bell's palsy?
So the first thing we would do is a CT scan, and if we see that there's areas of the brain that either didn't get enough blood flow or if there's a blood clot, then that definitely helps determine it. Bell's palsy Bell's palsy is a condition where you can also have weakness in the side of the face. There's other things that may be related to Bell's palsy. Sometimes it comes after a virus or other things, and so getting the patient's history, knowing what's been going on with the patient is also very helpful.
I did diagnose with mitral valve prolapse. Should I be concerned?
So mitral valve prolapse, let me see if I'll go back to the picture of the heart. So this is a picture of the heart, and this is the mitral valve right here. What mitral valve prolapse is one of these leaflets of this valve actually goes backward a little bit, and it leads to some backward flow of blood. So provided there's not substantial backward flow of blood, it's okay. But when there's a large amount of backward flow of blood, this chamber starts getting a little bit enlarged because it has to accommodate all that extra blood flow. That can be a risk factor for atrial fibrillation, but I'm talking long-term and with a large amount of backflow of blood. So we grade that prolapse as mild, moderate, and severe. In patients that have mild prolapse, and mild backflow of blood, we don't typically see too much, but it's long-term that's a problem.
Yeah, I did mine as mild.
Okay. So in patients like you, we typically will follow up with ultrasounds serially just to make sure that it's not progressing or getting worse. Ultrasounds of the heart or echocardiograms.
Dr. Matchison is my doctor, so I have to see him next month.
Well, there you go. You had a question?
When you were talking about diabetes, I always get checked for that because it does run in my family. So I get those pains in my feet and my toes, like somebody's taken a screwdriver in the end of my, especially my big toe. And I get pains all up and down my legs that are like electrical shocks. But I don't have diabetes or anything. I got it checked all the time in a year.
So that definitely sounds like a neuropathy, what you're describing, and patients can get neuropathy outside of diabetes due to a variety of reasons. So best to talk to your primary doctor. There's definitely other causes besides diabetes.
I tell her all the time, but she never does anything, and I just want to worry about it all the time because I have that hypnic jerk. So that I know that, but that's not my toes, the way my toes get. They get numb sometimes.
There's definitely a variable, different number of conditions that can cause it. You need to make sure that the blood flow to your legs are okay, so you're making sure that the blood flow down there is okay.
I wear the support stops.
Yeah. So the fact that your sugars
There's never an answer for me.
the fact that your sugar's okay is very reassuring, and it just suggests that you don't have the diabetic neuropathy, which is good. You had a question?
Do you have an opinion of the drugs, Coumadin and
So I was always a fan of Coumadin. So pros and cons of everything. So I personally used to like Coumadin almost exclusively just because your risk of bleeding is less. Coumadin has an antidote to it, vitamin K. So let's say somebody is on Coumadin for atrial fibrillation or for another reason, and they're in a car accident, they come to the ER because they're bleeding. You can give somebody vitamin K, which is an antidote to that, and that can stop the bleeding. So I was a fan of that. One thing I don't like Coumadin for is that you have to get blood work done initially every few days, and then when you're stable on it once a month to make sure your dosing is okay. The Coumadin is also affected by your diet. So if you eat a diet high in vitamin K, things like avocados or spinach, that can actually cause your Coumadin level to get a little off. The newer medicines, Xarelto, Pradaxa, those are a little bit better in that you just take one pill a day. You don't need to get the blood checked to see how thin it is. But previously there wasn't an antidote to that. But now they are coming up with antidotes to that, so it's definitely changing how we prescribe. So I used to prescribe exclusively Coumadin, but now I definitely prescribe Pradaxa, Xarelto. We have to use them in caution in patients that are over age 75. And then we have to use them with caution in patients that have kidney disease. So provided they fit the profile, I think those are probably the way I go now. Yes?
I've heard people talk about when they get put on medication for like high cholesterol, that they intend, because a lot of people don't want to do that, and so they'll wait, and then they'll say, okay, I'll do it, but I'm going to get off of it as soon as my cholesterol gets down. What's the process of that, or is that realistic for people?
So I'm very honest with people before I start the medicine that they're most likely not going to get off the cholesterol medicine unless there's substantial changes to lifestyle. A large component of cholesterol is also hereditary, and that part you just can't control. So patients will oftentimes start a cholesterol medication. The most common group is called a statin. You might hear simvastatin, lovastatin, Zocor, and these medications, their cholesterol will go down with this, but the problem is that their cholesterol went down because they're taking the medicine. So then people stop taking it. They won't necessarily tell me, but they'll stop taking the medicine, and then their cholesterol will go right back up. And so then they'll say, well, it's not working. But you have to be on these medicines very regularly, and you have to take them in the appropriate way they're prescribed. These medicines, the statins specifically, should not be mixed with any grapefruit products, like grapefruit juice or fresh grapefruit. It affects how the statins are metabolized. Also, it's most important to take these right at night just before going to sleep. These statins are not as effective if you take it first thing in the morning or even midday. I tell patients to take it at night just before they go right before they go to sleep. Your body produces most of the cholesterol in the evening at night when you're sleeping, and so if you're taking this medicine and it's in the highest concentration in your blood while you're sleeping, producing the most cholesterol, that's when it's most effective. Yes?
Every night, when I lay down and won't stop, I can hear my heart. Why does it do that?
Well, some people just have very good hearing. That's
Well, I just had a new baby's heart.
Oh, okay. So that's a little bit different.
Well, is that related to it?
Absolutely. So when somebody has a prosthetic valve or an artificial valve put in, whether it's more likely, do you have a mechanical valve or the tissue?
They also,
Okay. But is it a tissue valve or is it a mechanical valve? Metal? Do you take a blood thinner?
they replaced my head also.
Right.
My leg, went to the-
Oh, you had the TAVR. Okay. So, got it. Okay, so
Before that, whenever I lay down, with one, when I lay down on a certain side, I can hear it.
So we oftentimes have patients that have new valves put in. There's definitely a sound to them, especially in the metal valves that people get placed. It's the sound of two pieces of metal hitting each other. From what you're describing, you don't have a metal valve, but you do have a new valve, and sometimes people hear it. No, you'll probably hear it forever. And then even before the valve, you may have heard it. People get valve replacements because there's calcium that forms on the valves, and so that when the leaflets hit each other and they have calcium on it, people hear that as well. So that's not uncommon. It's not necessarily dangerous, but it's not uncommon.
Is that a new valve that's put in?
I'm sorry?
Was that a new valve that's put in with the calcium?
No. But just a new valve that's put in, especially the metal ones, because it's metal hitting metal. It definitely makes a sound.
That was my husband's problem. He had calcium buildup on
Mhm.
one valve, and it wasn't closing.
Right.
It was just staying open, and he did get a stroke.
And sometimes it happens the other way, where there's so much calcium that it doesn't actually open, and that's a different condition that people have. Another reason to replace the valve.
It would kill him.
I'm sorry to hear that. Any other questions?
My heart doctor suggested that I reduce my calcium intake, but then I have osteopenia,
Uh-huh.
and so I need to take calcium for that, so I cut in between the two.
It's really a balance. We find that a lot of things in medicine are a balance. And some people whose heart pumping function is low, they have something called heart failure. And so they can't take too much fluid in because they'll retain too much fluid. But then if you don't take in enough water, you can damage the kidneys. So a lot of medicine is a balance where you want to have enough fluid in your body to protect, to allow your heart to function properly and to have good kidney function, but you don't want to have too much fluid that your heart gets overloaded. And it's the same with calcium. You want to make sure that there's not calcium deposits in your body, but you also want to make sure you have enough calcium to fix your bones. So
Well, I do it happened to me, I was taking 1,000 mgs of cotton, I'm taking 500, so
that sounds like a fair compromise.
Question, when you mentioned taking the statin at night, I've read a couple articles where they talk about high blood pressure medicine, taking it in the evening, and if it's diuretic, that's nonsense.
I know.
So what are your thoughts on that?
So this comes up very frequently. So what I typically do is I have patients, when I'm adjusting their blood pressure medicines, take a blood pressure every day, maybe 3 times a day, morning, afternoon, and night if they can, for about a week or two. When they bring in those readings to the office, I can get a sense of what their blood pressure is at different times of the day, and based on which drug I give them, I can dose it. So sometimes in some patients who have really high blood pressure, 10, 11 a.m. in the morning, I'll have them take their blood pressure medicine in the morning. Other patients, if they take that blood pressure medicine in the morning, they might feel dizzy. Then those patients I'll have take it at night. So it's very dependent on the patient and what their blood pressure readings are throughout the day. My goal is for people to have blood pressure that's constant pretty much throughout the day.
That makes sense, thank you. And you mentioned someone who had a stroke and had blockage in carotid artery, surgery to clean them out. But if they have had a stroke, they probably have a blood clotting problem. So isn't giving them anesthesia and working in that area potentially creating blood clots in the heart that might travel up through the carotid?
It's definitely a risk, and when they do some of these procedures, they actually use kind of a net that they install, that they put in before they do the procedure to collect any, for lack of a better word, debris or cholesterol plaque that may travel. So they actually try to prevent it from going to the brain by putting a little bit of a net to collect it, and then they take that out after they're done the procedure.
So they're putting a net inside the drain,
Inside the blood vessels,
inside,
but a little bit further from where they're working, so if any cholesterol debris or cholesterol plaque comes off, they're able to retrieve it.
Interesting. Like a sink strainer, a spinach strainer. Okay.
That's a good
that makes
analogy.
sense.
That's a good analogy.
Okay.
Yes.
What does grapefruit juice do for statins?
So it makes the statins not quite as effective, and so you're not getting the full benefit from them. The way the grapefruit is metabolized by the liver is using the same system as the statins being metabolized by the liver, and so they're just not as effective.
What can a person do that has aphid? You mentioned some things here, but what is probably best? Exercise? Is it
So-
morning or?
So once the patient's already been diagnosed, the first thing that we try to do is try to get them back into the normal rhythm. The first thing what I always do for my patients is I'll try to give them an electrical shock once, maybe even twice, to get them back into the rhythm. And then we put patients on a class of medicines called antiarrhythmics that try to keep them in the sinus rhythm. If that still doesn't work, then we have to the next thing we do is just keep them on the blood thinning medicine long term.
How many times do you do that?
I mean, in theory, indefinitely you can do it, but indefinite number of times. But after 2 times, if patients go back into AFib, then I stop trying to do it just because it's not effective. There's a risk of burning and risk of other things with this shock, so it's not a benign thing to do.
That's what they did with my son. He had that shock
Mhm.
twice, 3 times. What about the ablation?
Ablation, yeah, that's a very good point. So in some patients that maybe they can't take a lifestyle where they're in atrial fibrillation, or if the atrial fibrillation still can't be controlled with the medicines, there is a procedure called an ablation procedure that's performed by specific doctors called electrophysiologists. And what they're able to do is either burn or actually freeze the tissue that causes the atrial fibrillation. It's a complicated procedure. It comes with risks, but in patients that do well, their lifestyle's changed.
This ablation doesn't cause the scars in the heart.
It's a purposeful scar where they don't want that electrical signal to conduct the atrial fibrillation, so they actually create a scar either by burning the tissue or freezing the tissue. So it is a scar, but it's a very purposeful scar in a very localized area to prevent that, but it's not affecting the way your heart beats.
Does it make-
Once I have 2 cardiac versions. Now they might do it again, ablation.
Yeah.
But it took 7.5 hours.
Yeah, it's a long, complicated procedure. Because they're creating a scar in your heart, they want to make sure that they're in the exact correct spot. They want to burn and freeze as little tissue as possible, so they do it very slowly, very strategically.
What is the percentage of success on the second one?
To be honest, it really depends on the person doing the procedure, and it depends on the patient population that doctor sees, so I don't know the answer to that.
I have a question on, when you have AFib, as long as I've had it, does your heart get rigid? That after a while, does it, because I skip a beat all the time. 2 years ago, my heart was fine.
It's kind of more the opposite way, where the heart becomes a little bit rigid, usually due to high blood pressure, and that's what causes the atrial fibrillation in the first place.
You have high blood pressure.
Well, patients that have high blood pressure, their heart becomes a little bit rigid over time, or we call it non-compliant, and that's oftentimes what leads to.
My blood pressure is so low, they tell me at 9, I'm
Yeah,
next to 9.
there's absolutely other causes of atrial fibrillation, and we see a genetic predisposition to that as well. But patients that get atrial fibrillation usually get it because their heart is non-compliant, meaning it doesn't relax properly.
You have that long-term AFib,
Mhm.
that second procedure, would that work?
The ablation procedure, it depends on the patients, and it's a specialist that would be able to answer the question as to who the appropriate candidates are.
Because his doctor said that he's chronic AFib,
Mm-hmm.
so he suggests not doing that second
Yeah.
procedure.
Some patients that have had atrial fibrillation for a long period of time, the heart kind of changes shape a little bit and becomes a lot more difficult to do the procedure, and it's less successful. Like she was saying, it's a 7.5-hour procedure sometimes, and so if you're going to go through that much trauma, they don't want to put you through it unless there's a high likelihood that you'll be successful.
So AFib can show up as a result of having a long-term other heart problem?
Yeah. So in some patients that have problems with one of their valves, long mitral valve prolapse, or even something else called mitral stenosis, where there's a narrowing in the mitral valve, that can cause your heart to change shape a little bit because the blood flow is not going adequately through the heart, and that can lead to AFib.
You know, people are so frightened of having AFib.
Yeah.
But I want to tell any of you that do have it. My mother lived with it until she was 87 years old. And I used to watch her monitor when we go to the hospital. Oh my goodness, and we go, oh my God. And mother lived to be 87. So I don't worry about it like I used to. Years ago, they used to tell me all this crazy stuff that I had to be near a facility. I couldn't go on vacation. Blah, blah, blah. Live your life.
I think it's also the medications have improved substantially, and how we give the medications improved. So I think patients are doing better these days.
I think so.
Any other questions?
What's the rejection rate for valves replacements?
So the word rejection is a little bit of a not great word. So rejection usually refers to somebody else's body part being put in you, but when we do valves, we typically use either metal or we use prosthetic or from pig parts, porcine valves. And so the rejection meaning that your body is saying, it's a foreign body, I'm not taking it, it's not that high. It's sometimes the valve does fail though. The failure rate really depends on the patient and the surgeon doing the procedure. It's a very complicated procedure, so I don't know that there's a universal rate. Any other questions?
Well, thank you, then.
My pleasure. Thank you so much for having me. I believe she passed around my card, so if you guys have any questions or you ever want to have a consultation, please feel free to reach out. Thank you.
Thank you so much.
I wanted to let all of you know that the next seminar, in case you're not on the email list, if you want to be on the email list and you're not, please leave me your email address. But our next seminar is going to be on Wednesday, March 16th, and it's going to be a panel of speakers that are going to be talking about planning ahead. So planning ahead for your future, for your loved ones, that kind of thing. So we've got some different panel of, I think it's 5 speakers that are going to be talking. So, and that's the same time frame, so 6 o'clock to 7:30. Okay? All right. The 16th. That's a Wednesday. I have one flyer. I have some more flyers up in the front office if anybody wants to pick one up.